At the beginning of this day, when we were asked to raise our hands for whatever role we were playing, it was interesting to me that when we were asked how many of you are patients or patient advocates, only a couple hands went up. But you know what? This is all about us. This whole conference is about us because we're all patients. Some of us are patient advocates, and I happen to be both. However, when Michael first called me and asked me to come present, I thought to myself, what in the world do I have to contribute to this group? I started looking at everybody that was presenting and the people that were attending and the sponsors. And I mean, I don't have any slides. I don't even have any letters after my name. And I started doing that thing that my brother always used to call stinkin' thinking. I'm not good enough. I can't compete and I can't compare. And it's a behavior that I actually learned. I was conditioned to be that way because I was born with a very rare hereditary bleeding disorder. However, what my bio doesn't say is it wasn't diagnosed till I was 47. And after multiple surgeries and bleeds and hospitalizations and always being told that I couldn't possibly have hemophilia because I'm a female. Women are supposed to bleed. So I was hindered also in that behavior. The psychosocial damage of being told there's nothing wrong with me was long-term. I got over it, by the way. But I also had a real barrier to conditioning, and it was, I come from a family of nurses. My mother was a head nurse at a large hospital. Both my sisters are nurses. One of them claims that she became a nurse because she spent so much time taking care of me when I was younger that she figured she might as well get paid for it. I grew up in the 50s. Nobody challenged anything a doctor said, and I was encouraged never to question because doctors were gods, and they knew all the answers. And when I finally figured out they didn't, and my apologies to those of you here who are MDs who still think you are gods, you aren't. But you're wonderful people. And I was still in that mode of never questioning until I finally found my voice. And I found it in a way that I was validated about finally being diagnosed with a bleeding disorder, and I wasn't crazy, and I wasn't normal, and I could take care of myself. But the first hematologist who diagnosed me said, you know, Barb, I'm a hematologist specializing in people with hemophilia. I've never had a factor VII deficient patient. So I'm going to challenge you to learn everything you can about your disorder, and I want you to educate all of your providers. So now here I am, this passive patient, being told, zip it, whenever I'm thinking about questioning a doctor, and my mother would give me that evil eye. Especially I remember one time after a routine tonsillectomy, I ended up in the hospital for 18 days on IV everything, fresh frozen plasma, cryoprecipitate, whole blood, which I got hundreds of units of over the years. And everybody kept saying, some people just bleed a lot, and she's one of them. Well, maybe it's because she's a tomboy or she's a klutz. And I remember because I kept bleeding in my throat after the tonsillectomy, and my mother actually questioned the doctor while he was in the room with me and asked, why is she still here? This was halfway through it, about the 9-day stage. He said, well, you know, she's a talker. And I told her not to talk. She'll loosen those sutures. And I started to open my mouth, and my mom just went, zip it. So I did. When I finally found my voice, shortly after that first hematologist told me that I needed to get educated, I was almost like a Marine in boot camp. I was really gung-ho. I was just killing all my family and friends because all I could talk about was factor VII deficiency. And do you know how rare it is? There's 1 in every 500,000 births, and only about 75% of them live to age 50, and blah, 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 blah. And after about, 2 minutes of the elevator speech, everybody would turn away. But I was getting myself prepared to be able to educate some of the providers. And because I have a tendency to have colon bleeding, I have to have frequent colonoscopies. I found myself in a new town, new state, new doctors, recently diagnosed, and I was preparing to educate a gastroenterologist. And I sat down and had my little notes in front of me and began explaining to him my deficiency. And about halfway through, he said, "It's okay. You know, I have a daughter that had idiopathic thrombocytopenia purpura, and she outgrew it." And I thought, yeah, but I don't outgrow this. But I didn't say anything. And I was explaining to him that because of my propensity for bleeding and because I have a tortuous bowel, that it would probably be good for him to use a pediatric scope. And he stopped me and said, "You know, you're a stewardess, right?" And I went, "Yeah." He said, "What makes you think you can tell me how to do your procedure?" And I stood up and I looked at him and I said, extend my hand, "Thank you very much for this consultation, but I'm not going to hire you for this job. And you need to learn to listen to patients." And then I turned and walked out, and then I looked back at him and said, "By the way, for 20 years we've been called flight attendants." Well, then I went down to my car and had a really good cry and thought, "Oh, gee, I really did find my voice, but it didn't work." So there was a barrier. How do I learn to talk? How do I learn to speak up? So what I did is I began connecting with people like me, people who had bleeding disorders, first through the National Hemophilia Foundation, and then when I realized there was no support group for women with bleeding disorders nationally, I started one. And it was just a little grassroots effort that started with a few people, and it mushroomed into over 1,000 members now. And at that point, I had to turn it over to someone who's younger and way smarter than I am. She happens to be an engineer for Boeing and runs it now. We connected. We connected first by phone calls and then by emails and then by social networking. And that really encouraged me to be able to speak up because I heard other horror stories. For one, I learned through the National Hemophilia Foundation that the average length of time for a male to be diagnosed with hemophilia is 1 week. You know, they do a circumcision and they have a bleeder and go, whoop, got a hemophiliac here. Average age for a woman is 27 years when she's usually hemorrhaged postpartum. And learning those things helped me to be able to speak to my providers in a way that they understood and that they also engaged me as I engaged them, and we became partners. And I like to say equal partners, and I use that expression because there's a person you're going to hear speaking later named Dr. Mark Pearson, who actually started up in the Whatcom region. You know, I don't know how many of you know that Whatcom County has one hospital, happens to be PeaceHealth St. Joseph Medical Center. And because of people like Mark, they're very innovative in getting patients as full partners on teams. We even have a patient who is a patient representative on the MedExec Council. She meets with the doctors once a month, and she sits in on credentialing. Our other patients are team members on joint quality and all kinds of things. And this has helped me to get an even bigger voice. It's also encouraged me to go out and to help others learn to have a voice and find out that through education and empowerment, you can actually get what you want most of the time. You just have to be a team member and get people on your teams. I now stay current with my support groups, I guess you'd call it, by networking socially. I belong to 4 separate groups. It's just been a huge boon. It beats the heck out of letter writing, believe me. And I came to computers late in life, so I can't see that. Is it time up? Yeah. Okay. Well, anyway, that's my story. I'm sticking to it, so go eat lunch.
Thank you, Barb. I'd like to ask the other speakers to come up, and we'll do a quick Q&A session. Jan and David. Did David rush off? He's riding his bicycle. There he is.
Hi, Sue Woods, VA. Any speakers, but Jan, you may want to tackle this first. So yesterday's New England Journal of Medicine had an essay by Jerome Groopman and another author that berated, it's called like the new language or something, and it berated the term consumer and provider. and it said, I can't remember exactly, but consumer, we can't call them consumers. We can't teach our physicians to call them, consumers. And then the provider, I'm a physician, and physicians should be called physicians and nurses. And I actually had trouble reading the article, the essay. So I'd be interested in your opinion about the term consumer.
Well, I'll leap into this with a moment that at a previous conference I found myself where everyone was very excited about the conversion of patients into consumers. It was some years ago. And finding myself frustrated going, oh, you mean people? Is that what we call these folks? People? But it's a very interesting institutional role. It's trying to reframe the relationship, which patient-provider or patient-physician is a different relationship than consumer-provider. But of course, given the nature of costs, there's an advantage to thinking about consumers. Well, I'm an this is not hopefully this is not too much of a segue or a departure from what you're asking. But, I'm an educator, and we're going through exactly the same thing as professors say. These are our students. They are not our consumers. So when you talk about the consumers, that's the wrong model. But, of course, one of the things that's inherent in being a consumer is that you have rights. And that's something that I think is worth for us to think about, is that consumers have rights because they're paying you. It does take away from the original sanctity and the specific nature of a physician and a patient. But there's actually a larger team than just physicians, and people are paying for this service. So it's a way of reframing some of those social roles that I think it's important for us to think about.
I'm going to ask a quick question. Thank you, all three of you, for telling great stories. I enjoyed listening. There's a lot of people, most people, that say that a person doesn't become engaged with their health until they have an emotional experience with their health. And I'm somebody that comes from the world of prevention originally, and so I'm wondering if any one of you guys, or all three of you, has perspective on, are you seeing anywhere in this space successful designs of triggering people to get more engaged in their health without having that emotional experience? And if so, where you're seeing that? Because we don't really want to design for a heart attack or something like that, right? So anywhere that you're seeing people getting really, really engaged in their health without being emotionally triggered first.
I think in our experience, I think sometimes people can engage with taking actions that contribute to their health, maybe without thinking of it as I'm doing something for my health today. So I'm engaged by competition, for example, with other people cycling. I think a lot of what we think about is being motivated by people around you, and you may think about. I think it's. I don't know. I guess maybe. I guess the question is whether people there's value in people just doing things without kind of waiting to say, I'm going to do something for my health today. And so hence a lot of the focus on gamification and on other ways to engage people. I think I guess there's a question. One of the questions about gamification is that actually just kind of tricking people into doing things? For some kind of extrinsic, you kind of take some other extrinsic motivator and kind of work toward that instead. And I guess the fine line is where, at what point you do something extrinsic and that helps you actually develop habits that you might like to keep. So.
One more?
Oh, I just wanted to jump in on that last one. The emotional configuration of what motivates people. I mean, that's outside of what an anthropologist usually deals with, but we deal with meaning a lot, and people have those relationships that mean something to them, the family members, the best friends. So you don't actually have to have that personal experience to have a meaningful emotional experience. And the degree to which you can look at that iconically or look at that in a metaphorical or symbolic way, that's pretty powerful too.
Yes, I have a question. Over the years, the research shows that the number of consumers who actually complain about things is very, very low, 1 to 3 to 5%. So have you seen any changes over the years in terms of consumer behaviors in relation to health? Are consumers complaining more on being more involved?
Are you Rita?
Yes.
Hello, Rita. Rita Robeson writes a consumer blog.
A reader blog for the PI.
Yep.
For boomers, baby boomers.
In my experience, when women who I predominantly am involved with in the bleeding disorders community get together and get a chance to talk and complain to each other, they're validated, and therefore they don't have as many complaints when they go to the physician.